Today we're going to be talking about acute aortic dissections, both medical and surgical issues. We'll talk about the natural history and classification, how do we image them, when and why do they occur, can we prevent them, and how do we treat them. Acute aortic dissections are the most common catastrophic event involving the aorta. A natural history study from Denmark demonstrated 5 cases per million per year versus only 3 per million for ruptured AAA. In the U.S., the incidence is estimated to be between 5 and 20 cases per million. It's a lethal disease if undiagnosed early and not treated appropriately. 30% mortality by 24 hours, 50% by 48 hours, and 90% by 3 months. The clinical manifestations, however, are protean. Approximately 50% of dissections are misdiagnosed initially. One needs to have a high index of suspicion. However, we need to remember that less than 1% of patients with chest or back pain that present in the emergency room actually have a dissection. In a natural history study from 1958, 505 patients were identified that had an acute aortic dissection. The most common age at presentation was between 40 and 70. However, there were presentations at both ends of the spectrum. The natural history demonstrates that at 48 hours there's a 50% mortality rate, approximately 1% per hour on average. The mortality continues to persist in the long term, though, as patients develop late complications of aortic dissection. There have been a number of classification systems that have been developed over the years. The two that are commonly in practice now are the Stanford classification and the DeBakey classification. This diagram demonstrates the difference between the Stanford A and B. The A involves the ascending aorta itself. B involves the descending aorta. The DeBakey classification, 1 starts in the ascending and goes all the way around. 2 is isolated just to the ascending, and 3 is isolated to the descending, potentially into the abdomen. Side branch involvement is common. There can either be compression of the side branch, as demonstrated on the left, or a tearing off of the side branch, as demonstrated on the right. Both can impact perfusion. The renals and peripheral vessels are most commonly affected, but side branch involvement can also involve the mesenterics, coronaries, cerebrals, and spinals. The most common cause of death in untreated type A dissections is intrapericardial rupture with tamponade, followed distantly by extrapericardial rupture or obstruction of aortic tributaries. The most common cause of death in untreated type B dissections is aortic rupture in 60%, followed by obstruction of aortic tributaries causing malperfusion in 40%. How do we image aortic dissections? The classic way to identify an aortic dissection is with CT scan imaging. It can be done quickly, and almost all emergency rooms have the capability to do this within 15 to 20 minutes. Here is a classic CT scan that demonstrates a type B aortic dissection with a flap demonstrated by the arrow. The true lumen has greater flow. The false lumen has lesser flow and therefore appears somewhat hazy in this particular case. Here is another CT scan demonstrating a type A aortic dissection with the flap present with a normal descending aorta. Here is another CT scan image demonstrating a dissection flap extending throughout the entire descending thoracic aorta. Intramural hematoma is a variant of aortic dissection, essentially a case in which a flap cannot be identified. Here we can see the hematoma present in the wall of the descending aorta. Transesophageal echocardiographic imaging can also be helpful, although oftentimes it takes longer to get a TEE in the emergency room than it does a CAT scan. Here we can see on the upper image a flap present in the ascending aorta, and on the lower image we can see flow in both the true and false lumens. More transesophageal echocardiographic imaging demonstrating a cross-section on the left with the dissection flap, and again another dissection flap in the ascending aorta on the right. Magnetic resonance imaging can also be helpful in more chronic cases. On the left we can see a DeBakey 2 or Stanford type A dissection, and on the right a DeBakey 3 or Stanford type B dissection. Chest X-ray is of very little value in acute aortic dissection as it has very low sensitivity and specificity. Transthoracic echocardiographic imaging can oftentimes identify a dissection, but it doesn't always rule it out. Transesophageal echocardiographic imaging is better for the ascending aorta. Oftentimes, though, it misses the arch. CT scan imaging is excellent as it's rapid and can be done in almost every emergency room. MRI imaging is ideal. However, it's time consuming and is better for chronic cases or for questions of branch vessel involvement. Aortography was classically the way to go, but is only done now in the cardiac catheterization laboratory under other circumstances. When and why do dissections occur? The classic patient is a male in his 50s who's hypertensive, but remember that's also the classic description of a patient with a coronary syndrome. Patients who are greater than 40 years old most often have atherosclerosis with hypertension or aortitis in older women. Patients who are less than 40 years old generally have a collagen vascular disease or a bicuspid aortic valve, in which case patients have a 5 to 18 times more common incidence of aortic dissection than with a tri-leaflet valve. Can we prevent aortic dissections? We did biaxial testing with force transducers in aortic tissue from 35 patients and found that there was a direct relationship between systolic blood pressure and wall stress and diameter. An increase in systolic blood pressure of 26 millimeters of mercury we found was equivalent to the increase in diameter of the wall equaling 1 centimeter. Older patients also had increased residual stress and decreased wall strength, demonstrating why aortic dissection may be more common in an older patient than a younger patient, given equivalent aortic size and pressure. Beta blockers have been used in Marfan syndrome to decrease hemodynamic stress. They've got a negative chronotropic and inotropic response. It's most effective, though, if they're started when the aorta is less than 40 millimeters in size. It does not prevent, though, growth or dissection. Some have suggested improved results with enalapril, ACE inhibitors, with increased distensibility and decreased stiffness of the aorta. Medical treatment of bicuspid aortic valves is unknown at this point, but beta blockers have been suggested to decrease the rate of growth over time. Losartan, AT1 antagonist, has been used in a mouse model and is now being used in humans. The mechanistic theory is that fibrillin 1 binds to TGF-beta, and TGF-beta overactivity is what occurs in Marfan syndrome. Losartan decreases TGF-beta activity. There has been decreased aortic growth compared to beta blockers or placebo. FedEx Group in Toronto also demonstrated the decrease in fibrillin 1 in bicuspid aortic walls. How do we prevent aortic dissections? Number one, by identifying high-risk groups. Hypertension is the most common culprit, collagen vascular diseases, and bicuspid valves with increased aortic size. We need to have good blood pressure control and potentially some exercise limitation if the ascending aorta is greater than 4 to 4.5 centimeters. How do we treat acute aortic dissections? Classic treatment is with surgical therapy, especially for type A aortic dissection. Looking at the original IRAD database of 645 patients, medical therapy was associated with a 58% mortality rate with type A dissection, surgical treatment 26%. With a type B dissection, though, medical therapy had an 11% versus 31% mortality rate with surgical therapy. It's important to note that some patients, however, that obtained medical therapy for type A aortic dissections may have been excluded from this study, as consent may not have been obtained prior to death. The indications for surgical treatment in type A dissection is all patients deemed survivable. There's questionable indication for intramural hematoma. There's a 35% risk with these patients, but it's not as clear-cut as an indication as it is for aortic dissection. With penetrating atherosclerotic ulcers, there is also a significant risk of rupture, but each case has to be taken individually. For type B aortic dissection, the indications for surgery are more impending doom, including rupture, impending rupture, which does not include pleural effusion because that's very common in patients that are not about to rupture. Malperfusion can be considered for therapy peripheral vascularly, and there's persistent pain or uncontrolled hypertension. Surgical intervention can be done with hypothermic circulatory arrest, allowing a distal anastomosis to be performed with a felt buttress reconstruction. Hemiarch replacement can be performed if the tear extends into the arch. Some centers, commonly however, still perform cross-clamp repair of the ascending aorta alone. The goals of surgical therapy are to obviate the usual cause of death, reconstitute distal flow into the true lumen, correct compromise of contiguous aortic branches, restore aortic valve competence, resect the primary intimal tear ideally, and eliminate flow in the false lumen. However, this is seldom accomplished with ascending aortic replacement alone. At Washington University, over a 22-year period, 25 surgeons had replaced the ascending aorta for acute type A dissection in 201 patients. The mean age was 61 years. Early in the series, aortic valve replacement was common, over 50% of patients, but currently we only replace the aortic valve in less than 10% of patients. In addition, hemiarch replacement has been more common in the mid portions. There's been a tapering off lately with about a 30% incidence. Operative mortality is 16%. Independent predictors include concomitant aortic valve replacement, preoperative malperfusion, or non-Marfan syndrome. Stroke also occurs in about 5% of patients, with the independent predictors being intraoperative dissection, a history of cerebral vascular disease. Stroke and operative mortality were independent of the surgical technique. Long-term survival is similar with cross-clamping, hypothermic circulatory arrest, or when retrograde cerebral perfusion is added. Independent predictors of long-term late death include increased age, earlier operative year, and associated coronary artery disease. We have found that the impact of late systolic blood pressure control is paramount to decreasing the risk of reoperation in the long term. We have found that patients who've had consistent systolic blood pressures less than 120 millimeters of mercury have a 17% reoperation rate, while it increases to almost 65% in patients whose blood pressures are consistently over 140 millimeters of mercury. In addition, late beta blocker use is also very significantly related to the reoperation rate. In patients that take beta blockers, the reoperation rate is only 25% at 15 years, where it increases to 75% in patients who do not take beta blockers. We looked at the incidence of aortic growth depending on aortic diameter and compared to the interval between imaging studies for serial CT scans in the clinic. Our point was to try to identify for each aortic diameter what time interval would be appropriate to obtain serial imaging studies. We found that with a small aorta less than 35 millimeters, that yearly imaging studies was probably appropriate, but when the aorta got to be greater than 5 centimeters, that imaging at 6 to 9 months was probably most appropriate to pick up and identify incidences of aortic growth over time. Surgical treatment does not cure the generalized disease. Surgical management usually does not directly restore normal anatomy in the distal aorta. The Penn group has been championing doing simultaneous stent grafting for the descending aorta, which may improve this result, but this is still to be only done in very experienced centers. Postoperative close medical follow-up mandates strict blood pressure control, negative inotropic therapy, and serial imaging studies. Our initial goal in treating acute aortic dissection is get the patient out of the OR and out of the hospital. Uncomplicated type B dissections are usually treated with medical therapy in most centers. Acute operations are for complications only. The operative risk for emergent indications can be 50 to 75%. Predictors of increased operative risk include older age, rupture, and renal or visceral malperfusion. Some centers have championed operative early elective indications for replacement, but this requires a healthy patient, favorable anatomy, and probably a subacute setting. The risk of death with medical therapy is about 10 to 15% in most studies. The goals of medical therapy are to decrease aortic and left ventricular peak dPdt and reduce aortic pressure. However, we must maintain adequate perfusion of the coronary, cerebral, and renal circulation. Beta blockers are started initially, then vasodilators. We usually use afterload reducing agents as opposed to venous vasodilators. Decreasing blood pressure from hypertensive levels can oftentimes reverse malperfusion. Pain may wax and wane, potentially due to movement of the flap. Tight blood pressure control is the goal initially, but antihypertensive needs may decline following discharge, especially from the hospital. The original therapeutic options for distal malperfusion included an open fenestration, but we now have endovascular repair to help us with this complex problem. The initial use of stent grafts to fix the primary tear was presented by the Stanford group when they had 19 patients in their series back in 1999. They had a 16% mortality rate, which is acceptable considering the fact that these were all very complicated patients. These images demonstrate an acute type B dissection before on the left and after on the right, a stent graft being positioned to cover the proximal tear. The theoretical goals of endovascular therapy include to reverse malperfusion, re-expand the true lumen, and exclude or close the primary intimal tear, which potentially could obliterate the false lumen. However, this generally requires treatment of almost the entire length of the aortic dissection. The Vienna series demonstrated stent grafts implanted over the primary tear to thrombose the false lumen. At the level of the stent graft, it's very common at 1 year to have complete occlusion of the false lumen, but distal to the stent graft, for example at the celiac artery, occlusion of the false lumen or thrombosis only occurs in about 22% of patients long term. Looking at the IRAD database in 2006, there was 242 patients with an overall hospital mortality rate of 12% for acute type B dissection. Medical therapy was the most common approach undertaken. The indications for surgical therapy or endovascular therapy included recurrent pain, extent of the dissection, refractory hypertension, limb ischemia, visceral ischemia, or rupture. 3-year survival was similar when medical therapy, surgical therapy, and endovascular therapy were compared. This is important to remember, however, that the surgical and endovascular group essentially was a sicker group than the medical therapy group initially. Early diagnosis and institution of definitive therapy is the key to future progress. Essentially, all patients with acute type A dissections should undergo emergency operative interventions unless they have been deemed unrecoverable. It's important to note that the Yale group has studied subaortic dissections and have found it acceptable to perform surgery in more of a light of day type setting in these certain selected cases. Patients with uncomplicated acute type B dissections may be treated either medically or surgically if they develop a complication. Survival with medical therapy for type B dissections is excellent, but if medical therapy fails, emergency operation is required for major complications. The salvage rate will be low. For complicated acute type B dissections, mortality may be diminished with an endovascular approach if there's peripheral or central malperfusion. After initial medical therapy and or postoperatively following open or endovascular repair, close medical follow-up is essential. Blood pressure control should be obtained, ideally less than 120, certainly less than 140 millimeters of mercury systolic. Patients need to be aware of the importance of blood pressure control. Negative inotropic therapy is recommended in patients who can tolerate beta blockers, and routine serial surveillance imaging should occur indefinitely for the patients to follow up their residual thoracic and abdominal aortic dissections. Surgical indications for chronic type A or B dissections include documented expansion, symptoms, or size greater than 6 to 8 centimeters depending on the location and operative risk of the patient. Today we've covered acute aortic dissection, natural history, how do we image them, why they occur, can we prevent them, and how do we treat them. I would refer you to Approach to the Treatment of Aortic Dissection in Surgical Clinics of North America from 2009 for a more complete description of the diagnosis and treatment of this very common disease. Thank you very much.